Well, welcome. Today we are going to be discussing concussion. Rehabilitation today is the first part of our two-part series, and we're going to be discussing the vestibular and vision aspects of concussion today. My name is Sandra Wild-Sutton, and I am an occupational therapist with TheraPlay Incorporated. And today we also have a guest, Dr. Scott Edmonds. And Dr. Edmonds is with Wills Eye Hospital, and he's part of the Rothman Orthopedic Concussion Network. So welcome, and I hope that you're able to learn a little bit about concussion today. Any questions, please hold till the end and type them in, and we will answer all your questions to make sure that you have a positive experience tonight. So we're ready to begin. Okay. So let's just talk a little bit about the general background of what a concussion is and what concussion treatment is. Concussion treatment is really still an emerging field. Most of what we do is very research-based, and there are changes in the research all the time, and we're updating what we need to do to help service those clients of ours that do have concussions. There are changes based on research for increased safety on the field. The changes that research also impact are the protocols for our treatment, and then the research is also impacting the protocols for children to return to play. Generally, you want to seek treatment if you haven't gone to your initial emergency room or pediatrician or family doctor right after the concussion happens, and you have concussive symptoms that are lasting longer than 10 days, you should seek medical treatment and start thinking about talking to your doctor about a rehabilitation program for that concussion. Concussion and mild brain injury requires an integrated team approach, working not only with your physicians, possibly specialists, physical therapists, occupational therapists, speech and language pathologists. So your doctors will be able to direct you on the kind of treatment and specialists that you need to see. So let's talk about what a concussion is. A concussion is a complex metabolic and physiological injury that occurs in the brain, and it can happen from either a direct hit or an indirect force to the head, which can disrupt normal functioning. It can be caused from the direct forces such as falling, hitting your head, a blow to the head, as well as indirect forces such as whiplash or an acceleration or deceleration injuries. Diagnosis is usually based on a collection of symptoms, the neurologic impairments, and the mechanism of the injury. While there is no physical damage done to the brain, a concussion causes a metabolic crisis, and this can result in decreased function. Concussion is used along with the term mild brain injury because the recent research shows us that there can be long-term neurological deficits. Imaging can be done to rule in or out more serious pathology, such as intracranial hemorrhage. However, the extent of the concussion may not be able to be determined. Previously, return to sport took place once your initial symptoms have resolved, but now it's known that multiple incidents with a short period of time can lead to serious injury and even death. So there are a lot of different things that can happen with a concussion. Physically, when you have a concussion, immediately you may have a headache, or the headache may not even start until a day after the injury has occurred. You may initially have nausea and vomiting. Occasionally you'll have dizziness. You'll have vestibular issues. Vestibular means that you may have balance problems, difficulty knowing where your body is in space and understanding how fast or slow you are. The vestibular system is located in our inner ear, and it tells us a lot about what our posture is doing and how fast and slow our body is moving. Because of the vestibular issues, you may have balance problems. Many times there are visual changes, and we'll go into that in a little bit more detail. Many times you have fatigue, and you'll have oversensitivities, sometimes to sound, sometimes to light, many different things you can be oversensitive to, sometimes to touch, and you may have some cranial or some cervical injury that goes along with the concussion. Cognitively, you may have difficulties with memory, Kids may have difficulties with concentration where they never had that before. They may have a difficult time initiating tasks, and what you'll see is a harder time getting ready for school in the morning. It's taking them a lot longer, trouble initiating homework. They may have some forgetfulness or amnesia. They may have difficulty interacting with their friends socially. It may be more difficult for them to think of the language that they need to use. They may have some difficulties with reading comprehension and understanding everything that they need to read, and remembering the information that's presented to them in the classroom or in text. Emotionally, you're going to maybe possibly see some irritability. Sometimes kids are very sad after a concussion. This may lead to depression, and we'll cover a lot of the emotional parts of concussion in part 2 of our series. You may have some increased anxiety and what we call emotional layability. That means you may cry where you didn't cry before, or laugh where it might be a little inappropriate to do so. And there may be some personality changes. On the field right away, kids may run the wrong way. They may start to forget the play. You may see over time they're going to miss practices. They're going to have difficulty with time and space. They may be breaking rules of the game, and you're thinking, what's going on? And they may be less of a team player than they were before. We're going to start. Dr. Edmonds is going to take over the next part of the series and talk about some of the vision problems that you may see in concussion. Okay, Dr. Edmonds, go ahead.
Thanks, and hello, everybody. My name is Scott Edmonds. I'm an optometrist at Wills Eye Hospital, and I'm the co-director of the Low Vision and Contact Lens Service, of which traumatic brain injury is part of our low vision extension. So we have offices at Wills and Drexel Hill, as well as along with the Rothman people at their Glen Mills office, and we have a country in Fraser today. So I'm the senior partner of our group. It's a family practice. I practice along with my wife and both my sons, all of who are optometrists in our group, as well as some other doctors. So I'm here tonight to talk to you about specifically the vision-related problems from concussion and mild traumatic brain injury. I want to start a little bit with prevalence. How prevalent is the vision component in a concussion? And some recent study done by Dr. Master, who is actually at CHOP, has done a lot of research. She's a research physician at CHOP. And she published in 2015 that 69% of adolescents who have a concussion have some type of vision problem. So the most common were either accommodation, which is focusing for near, convergence, turning the eyes together, or saccadic dysfunction, which is the eye movement we use when we read. 46 of that group also had more than one vision disorder, so it wasn't just one system, it was multiple systems that were involved. In sports-related concussion, and a nice study done by Ellison they're published in the Journal of Neurosurgery Pediatrics in 2015, talked about sports-related concussions, an interesting change in that only about 28.6 or about 30% of the people who had a concussion in the immediate concussion period had vision symptoms. But after the immediate concussion heals, and then the post-concussion period, which can last, usually starts at about 6 weeks and can last for years if not treated, that 62.5% of patients with a concussion had vision symptoms in the long term. You can turn that to the next slide. So back one now. I don't seem to be able to turn the slides back here. There we go. So let's talk about the types of vision-related symptoms you could have. So in a mild concussion, sort of a common symptom is headaches. People can have blurred vision, and it can be either in the distance, they can't bring the distance into focus, or they can't bring things near into focus, or they can't change their focus from distance to near. That's another common problem. These people obviously have trouble with reading. When they attempt to read, they get eye strain, or their vision gets blurred even after a short period of reading. When they are reading, they're concentrating so hard on focusing that they can't concentrate on what they read. And their eyes are often uncomfortable while during reading or even after reading, attempting to read. In a moderate concussion, we see frank diplopia or double vision. There's sort of two types of this. The most common is horizontal or side-to-side double vision. That gets worse when they attempt to look at something close. People with a moderate concussion are often disoriented, and they're disoriented when they attempt to do visual tasks. So they might attempt to read and they find themselves confused, or look at a computer and get disoriented. And they can have some motion discomfort based on visual motion. So when they're riding in a car and they see the targets moving fast, they get dizzy. People have claustrophobia or difficulties well in the crowd or in traffic. The disorientation is a common problem, and it really it has its roots in the visual system. When we go to look at an object as it comes closer to us, our two eyes lock on the target, and as the target moves closer, the eyes need to converge. And this convergence actually tells the brain where the object is in space, so the brain knows where to focus and how close the object is. So if it's difficult to converge, patients need to use a lot of energy to try to converge their eyes, and when they use that energy, the brain thinks the object is unduly close. So people feel like things are in their visual space when they're actually at arm's length because their convergence system is giving them wrong information. In younger people, accommodation, which is focusing, as things come close, your brain normally autofocuses for the close distance. But because the convergence has disabled the distance judgment, the accommodation system doesn't know where to focus. So objects become blurred when they try to read, or if they can make them clear when they look to read, when they look into the distance, they can't unfocus their eye to the distance and blurry in the distance. We judge distances based on primarily on our convergence and accommodation. And when they're giving us wrong information, we can't judge size or even movement. And all this leads to a general disorientation, which is often difficult for the patient to describe. They clearly don't understand their visual system is giving them bad information. 70% of the information from the external world that goes to the brain comes through the visual system. But patients often describe having like an out-of-body experience or just feeling general discomfort or disorientation. They just know things aren't right, but they can't quite put their finger on the problem. So the theory of ocular motor dysfunction is that we have a network of neurons that control all the function around the brain. So the brain, no part of the brain is the master part of the brain. Each part of the brain has to communicate with the other lobes of the brain. And so signals race back and forth between the brain, and the concussion disrupts this neural network. So as mentioned earlier, the brain itself generally isn't injured, often doesn't show any changes on scanning, but this neural network is confused. The ocular motor nerves, which there are three nerves that control eye movement, and we'll talk about that in a little more detail, they're a common target to get information confused between the different ocular motor nerves, which leads to their dysfunction. In a general eye exam, if you go to a regular eye doctor, often concussion patients go to their family eye doctor, and their family eye doctor checks that everything's usually normal, everything tests normal, and the eye doctor says, well, your problems aren't coming from your eyes, and yet the symptoms are all visual. So when you go to a neuro-optometrist or a concussion eye doctor, we take a look not at how the single nerves move the eyes, but how they move in concert, how they move together. So the complex eye movements we look at are convergence, which is the ability to focus as things come closer. The saccadic eye movements are movements from point A to point B or point to point movements. When we read, our eyes actually jump from word to word to word, and each one of those little jumps is called a saccadic eye movement. Accommodation, which is the focusing of things as they come close and defocusing as they go further away. And the pursuit eye movement is the ability to pursue a moving target. So here's the neuroanatomy of the ocular muscle system. So you see this is the eye at the left, and in the back is the cranial nerve system where it comes out of the brain. So we actually have three different nerves. The ocular motor nerve, or the third cranial nerve, inserts here and follows out to it controls a number of the muscles on the eye. The trochlear nerve controls just one muscle, the trochlear muscle, and then the Gleason's nerve turns the eye out, or undoes convergence. So if you take a look at this model, you'll see where the trochlear nerve 4, and nerve 3 actually cross over right here in the anatomy of the brain. And so because those two nerves can touch each other, and not everybody's anatomy is the same. Some people, these nerves are in close proximity for a great distance of the nerve tract. Other people, these nerves don't actually touch, and they don't have these kind of problems. But when they touch, if the sheath of the nerve gets disrupted, so electrical signals that are coming from the brain trying to go to the third nerve end up going to the fourth nerve, then you're going to have eye movement mistakes. Likewise, you can see over here, the sixth cranial nerve crosses over the trochlear nerve here. And so it's easy to see how signals can get mixed up since there are 6 muscles for each eye, and 3 different nerves that run the eye on each side. That's quite a few nerves that have to all coordinate for your eye movements to be correct. So this is the reason why vision is a main component in concussion, is because of the number of nerves that control eye movement and how close in proximity they are to the brain as they travel through the head. So the research for vision therapy as a strategy, so the vision therapy world is a little new to the concussion world. For the most part, prior to 10 years ago, most therapy was not done by optometrists, were done by other therapists. But I think as the vision became a more important symptom, and especially in long-term concussion, then there was some research done, and this is all fairly recent research on strategies to use vision therapy that was often developed for children with ocular motor that don't develop correct eye movements. So using the vision therapy strategies and optometric testing, we were able to help diagnose the problems and then use the appropriate therapy. So here's a number of examples from various research. This piece was done by Dr. Scheiman at Salis over the optometry school in Elkins Park, and Dr. Bose, who's one of our local optometrists in the Exton area. They were the head of a large multi-study group that was at Bascom Palmer Eye Institute in Florida and at the Mayo Clinic. And this was published in 2008 and really demonstrated that for convergence insufficiency, a main problem in concussion, that office-based optometric vision therapy was very effective. So since this article was published in 2008, a number of other articles have been published to kind of support this with more advanced vision therapy strategies for concussion. Here's some more recent information. One to point out here is this Dr. Gazzelli, who was a neurologist at Berkeley in California. He's the one who developed a number of the computer program therapy protocols and developed the model for effective therapy for people with concussion and other neurological disease. So the program we do for vision therapy for concussion is a little bit different than the vision therapy program that's used for children and for developmental. These patients had normal eye movements up until the injury, so we have to have more of a rehabilitative strategy to help them get better. So these are the points that have been developed that what a vision therapy program needs to include. The first point is the program needs to be engaging. So the patient has to be actively involved in the therapy protocol. They can't just be going through the motions. They have to have the therapy protocols have to be engaged. We use a lot of stereo images and stereo targets in a computer-based system, so we can alter the target to make it visually interesting for different age groups. The program has to be targeted, so you can't do convergence therapy for a saccade problem or accommodation problem. So you really have to target the therapy programs around the specific eye movement in question. The program has to be personalized. Not everybody responds to the same therapy. A lot of patients, when we have our computer-based therapy, the computer either scares them or makes them kind of uneasy, and so we move to free-based therapy, which we do with prisms and loose lenses in free space rather than using a computer. So each person, the program, we can't use a cookbook approach. We have to personalize it for each patient with a concussion. The program has to be repetitive. So once you find a movement exercise that helps the patient and you see that it's making a difference, you have to repeat this and you have to reestablish the patterns of eye movements that are normal. The program has to have biofeedback. So when the patient responds correctly to the targets, there needs to be a way that they know that they did it correctly. So the system we use has a series of beeps and boops. The beep tone is a very pleasant tone, so if you execute the eye movement correctly for the target, you get a pleasant beep tone. If you miss it, you get a boot tone. The brain quickly learns to respond to the positive and negative reinforcement with the different tones and quickly can adjust when it realizes it made the wrong eye movement. The program needs to be progressive, so we use what's called a closed loop. So we try, for instance, if we're doing vergence therapy and we use 1 prism diopter and 2 prism diopter, and then the patient starts to break down, the therapy would back up to 1 and come again cross the threshold. So it has to keep going back and forth over the threshold to keep the threshold to advance forward. So this is called closed loop processing, where you constantly change, but you don't do therapy beyond the range they can do because it's ineffective. You've got to work in the range that's achievable, but keep moving that goal into the normal levels of eye movement. The programs need to be competitive. The patient needs to be trying to beat their score at the last time they took the session or trying to beat the the best score for their age group. So competition tends to drive people into trying to be more competitive with the therapy, and it's more engaging if the program is competitive. And the last piece is that the program needs to cross over. So being able to execute all of our computer therapy programs and get high scores will be really meaningless if that isn't translating to better reading, less symptoms, less headaches, more comfort, better vision at distance or near. So there has to be a crossover in everyday life. So in our therapy program, after each half an hour session with the therapist, the patient meets with the doctor to review how the therapy session went, whether they were improving, and whether or not it's making an effect in their reading, homework, studies, or whatever activities that they're involved in. So in addition to eye movement, there's an issue called cognitive motion. So cognitive motion is the brain's ability to address multiple moving targets. So probably the most common example of this is when you're driving. When you drive, you have to know where to put your eyes to keep the car on the road, but you need to monitor the oncoming traffic. You need to monitor the traffic in your rear view mirrors. So your brain and your eyes need to be constantly shifting around your environment, but yet only staying a short time on the areas so that you're monitoring and concentrate on the areas where you're putting the automobile. So you can't take your eyes off the road to study the rear view mirror for 5 minutes or you'll run the car off the road. So concussion patients are often impaired in their ability as to where to turn their eyes over what activity. So we have a therapy program called the NeuroTracker, which helps people kind of readjust in a safe environment to this cognitive motion problem. So the different diagnosis treatments for convergence insufficiency, one of our most common problems, it's standard what we call orthoptic therapy and prism therapy, where we use different amounts of prism to stimulate the convergence and divergence system. In patients with an accommodation problem, it's a combination of the orthoptic therapy, which is sort of traditional vision therapy, but we also use cycloplegics or eye drops that will paralyze the focusing mechanism. Sometimes we do that to let it rest. Sometimes we do that to kind of stimulate it in different ways. And we use plus lenses that help the eye focus it near, so we can get the eye to be able to change focus to different powers of plus lenses. For saccadic eye movements, we use a vision integration therapy program, a program that helps them move their eyes in different directions, responding to different targets, and we can judge, the computer can measure speed of response and accuracy of response. And we also use the NeuroTracker for cognitive motion, because saccadic eye movements seem to be the root of cognitive motion dysfunction. And for people who have trouble with their smooth pursuits, we do use both the vision integration strategy and the NeuroTracker cognitive motion therapy. A lot of patients that have trouble with their vision have photophobia, and so they present with aversion to light. This, as we believe that this comes from kind of the brain is not getting the proper response from the other parts of the brain, and so when it doesn't really get the signal it's looking for, the brain kind of turns up the gain, if you will. It tries to listen more carefully for the correct signal. And when any signal comes by, it kind of blows the speakers out. So people, and it's not just photophobia. Often these people are sensitive to noise or sound or to a busy environment, and sometimes even they're emotionally irritated because they're just ultra sensitive, because the brain is just not getting correct signaling, and it's trying to listen for the correct signal. Once we normalize this input to the brain, a lot of the photophobia will decrease on its own. But in the meantime, we often use a series of filters that are made by the Chadwick people, or the chromogen lenses, which is a series of different colored lenses to help people adjust to a comfortable environment. People that have eye strain, we also use monocular occlusion, or we occlude one eye so that they don't have that binocular stimulation. Or we can occlude part of one eye, what we call binasal occlusion, so they still keep both eyes open, but part of the visual field is muted, so they don't have as much difficulty. We use prism lenses either temporarily with the temporary prism glasses. We use prisms as part of our therapy. And sometimes in more complicated cases, we actually prescribe prism glasses for long-term wear. The use of specialty contact lenses where we can change the focus of one eye distance, one eye near, especially for older patients. This can help break up their binocular stimulation and make them more comfortable while they're recovering. So neuro-based rehabilitation is kind of the complex term we use this because it goes beyond just vision therapy. As we've seen, we use other strategies. So we have sort of a two-part strategy. One is reestablishing normal visual input. So we got to make sure the brain is getting kind of normal input. And if the eye movements are incorrect or the eye muscles are misaligned, we'll use prisms. We use lenses to focus for different focal distance. We use filters, or we use occlusion. So any combination of these strategies are used to first develop normal visual input, and then we use our therapy programs to reestablish normal vision. So if you think of it as recalibrating the visual system, once you normalize the input, you can recalibrate through progressive orthoptics, vision integration, or our cognitive motion strategy. At the Rothman Concussion Network, we really use a comprehensive approach. So I've spoken tonight just about the vision aspect of therapy, and certainly as we saw from the research, vision is a big portion of concussion, but it's not the only portion. So our team at Rothman includes some physicians that are either neurologists or physiatrists, some sports medicine doctors, and some specially trained nurse practitioners trained in neuro. We have our optometry and our psychology team with our group leading the optometry, and you're going to hear in the second session from our team psychologist on the role of the psychologist in concussion management. And then the therapies are done by physical therapists, occupational therapists, and at the Rothman we also use athletic trainers in a number of different roles in the process, along with medical assistants and vision therapists. Concussion and brain injury management really requires an integrated team. It's hardly ever just one system that's impaired. And the Rothman group has developed this network, virtual network, because it includes a number of groups, including Theraplay and a number of other groups that kind of work together through using the internet and to be able to communicate back and forth. This team approach gives us the best outcomes in concussion management. So my conclusion for my part of this is that vision is really a key component of self-awareness. As I said, 70% of your input to the brain comes from the visual system. Reestablishing vision and visual perception is an important aspect of the overall recovery to a concussion. And an optometric vision therapy is an important part of a comprehensive recovery plan.
Okay, so now we'll turn the program back over to me, and we'll talk a little bit about what physical therapists, occupational therapists, and speech therapists can do for you. So one of the things I just want to mention is that you always have two options: to go and seek out services from your medical professionals and therapists and think about getting rehabilitative treatment, or not. And one of the things that we see in research for patients between the ages of 5 and 18 years with acute concussions is that when we look at their physical activity within 7 days after an acute injury, compared to people who have no physical activity, they have a decreased risk of persistent post-concussion symptoms at 28 days. And so obviously we're advising you to go out and get that medical assistance sooner rather than later to decrease your concussion symptoms. So like I said before, the vision system works very closely with something called the vestibular system. So we all learn in school that we have 5 senses. That's actually wrong. The vestibular is another one of those senses, and it helps to play a dominant role in the subjective sensation of movement and spatial orientation of the head. It adjusts your reaction or your muscular activity and your body position to maintain that head posture. And that's why sometimes you'll see when people are having vision difficulties, they may tilt their head or hold their head just slightly differently than they might prior to the concussion. And the other thing that the vestibular system does is it stabilizes the fixation point of your eyes when your head moves, so that your eyes don't just spin around in your head. And it helps you provide that stable image on the retina. The easiest way to understand the vestibular system is many of you, I'm sure, have been sitting in a car at a stoplight, and out of the corner of your eye, you catch the car next to you moving, and then you slam on the brake as fast as you can, only to realize that your car didn't move at all. And that's actually your vestibular and your visual system playing a small trick on you, thinking that your body moved, when in reality it didn't move at all. So one of the things that we're really concerned about, as I'm sure Dr. Edmonds is not only return to sport, but return to school. Return to school is really one of the things that we need to look at first, because all of our athletes are students first. And when they come to therapy, we're looking at a 5-stage program to getting them back to school and back to their sport. And the first stage really looks at having very minimal exertion. We're assessing what your headache status is with exercise, without exercise. We're looking at a pain scale and checking in with you frequently within that treatment hour to see if that pain scale is changing with what we're doing. So we're really doing a lot of monitoring of what your pain is. We may start with vision exercises in isolation, and we'll do things called habitual exercises. And habitual exercises are those exercises that you do almost out of habit. You stand up, you sit down, you lay down in your bed, you sit back up. You roll from your back to your side and back to your back again. That's really what habitual exercises are. And so we start to get that head moving so that that vestibular system and that visual system are starting to work together. Then we move, as kids are able to, we move to stage 2. We want to make sure, really, at the beginning that we have that cervical spine clearance, but in stage 2 it really becomes critical because we're doing a lot more head movement. We're going to be doing a lot of active range of motion, which is your student moving their head on their own, and passive range of motion, that PROM, which is the therapist moving your child's head. We're looking for muscle flexibility, muscle strength, and we're providing exercises that combine that use of that vision and the vestibular system. So in that second stage, we're starting to combine things a little bit more, and now you're going to be moving as we ask you to do some of the visual exercises, where before we might have done them in a more static position. As we get to stage 3, therapy becomes a little bit more moderate to aggressive. The way we would look at what's going on with your vestibular system is something called the Dixau Pike. We might also assess it through something called the roll test. And we provide activities that stimulate the use of that vestibular ocular reflex, which is controlling your ability to look at items as your head moves. We provide vision exercises that focus on not only regaining that endurance for task performance, but also looking at task performance as far as reading and academic skills. We're also looking at balance. We might do a test called the Clinical Test of Sensory Organization and Balance that looks at your ability to balance on 2 feet, on 1 foot, on an unstable surface, and on a stable surface. We might do something called the BOT2, which is the Brudzinski-Ortevsky test of motor coordination. And 2 just means it's the second version, but that takes a look at those bilateral coordination skills, or those skills that are used on both sides of your body. We might do something called the BEST, which is the Balance Error Scoring System, that also looks at your balance and your ability to maintain that balance. We're also going to listen to the feedback from the athlete or the student as to what's going on and where are they losing their balance, where are they having the most problems. We're also going to provide visual exercises that require head movement, and we're going to do it in all planes. So when your head is up and erect, when you're laying on your side, we're going to have you bend down so that your head is near your feet. So we're moving you through all the planes that you might be moving your head. In stage 4, we're really focused on those return to school aspects. By stage 4, actually towards stage 3, we want a child back to school full time, and we want to start looking at, are they getting their homework assignments done? Are they starting to be able to remember what's going on that they need for testing situations? Are we looking at a way to catch up the academic skills that they've missed? And we're looking at functioning skills like planning and organizing, their ability to manage their time, their ability to use that working memory, and ability to shift within tasks. One of the classic things that I do in therapy is I'll put kids on a treadmill and I'll ask them to do their multiplication tables, and they need to shift between 1 times 1 is 1 and then go back to 1 times 2 is 2 and do all that shifting while they're working. We're going to work on skills called metacognition. Metacognition is the ability to understand what you know, what your strengths are, what your weaknesses are, what you still need to work on. That's metacognition. And then we want to initiate plans, again, to meet those homework and testing demands. We're also going to look at a child's skills to inhibit, as far as looking around the room, their ability to be impulsive or really be able to control their behaviors, which may have changed since their concussion. We're going to look at their emotional control. Are they managing their emotions closer to where those emotions were prior to their concussion? Are they able to sustain their attention, which vision is going to really impact attention? And so what's going on with attention now? Is vision still impacting that? Are they able to initiate their task and really participate in getting things done by initiating when they're asked to initiate? Do they have flexibility within those academic tasks to maybe stop math and move on to reading because reading is the priority right now and that homework needs to get done? And do they have the persistence that they need in order to get their work done? Stage 5 is really, we're looking at, we're back to school full time, we're able to do homework assignments, we're ready to get back to testing, we're performing on those tests, pretty similar to what we were doing pre-concussion. We're looking at the improvement of all those cervical spine impairments. At this time, the kids are still stretching. We're looking at their educational demands. We're looking at strengthening them. Because many times after concussion, you're resting first, and your body deconditions much faster than you think it does. And so getting it back and ready to return to sport is a process where we have to build that endurance. We're looking at manual therapy, possibly deep neck flexor protocols if we need to. We're coordinating with any doctors that we need to for your visual impairment. We're working in all planes and positions. We're doing at least 50 minutes of aerobics, so over an hour in therapy. You should be running and moving the entire time in this stage, as well as working those saccadic eye movements, those visual pursuits, convergent skills that Dr. Edmonds had talked about. We're looking at the full academic rigors, and we're starting to look at your sports rigors and really getting you back on the field, starting to work with your trainer to get you to the point where you can start to think about returning to that sport, but not yet totally contact. I'm going to just show you a sample therapy session. This young lady was a gymnast working on the national level. And you can see that we were working on visual skills as well as those vestibular movement, balance, and she's working through all the planes of movement, and she's trying to, as she gets a beanbag of a certain color, hit the dot that she needs to hit. So it's a really pretty complex task because she's working on, you think pretty simple cognitive skills, but it is a little bit harder in the moment. And then here is a balance activity. Obviously, she needs to get back to beam work. This is somebody who needs to do very complex tasks on the beam. But initially, we just need to see that balance on the balance beam with head movement. And so this is an activity that we might have seen her do through her concussion. The road to recovery is, working on those academic skills as well as sports. We can also work on making recommendations. In Pennsylvania, there is a program called Brain Steps that works with our intermediate units and can provide education to area school systems on how to work with children athletes or student athletes to get back to school and to build school skills. Mild head injury, a concussion, is very different than a learning disability, and so teachers are going to need to treat it very differently. And so Brain Steps is one of those organizations that can help school systems build their return to school and return to play programs. It is in Pennsylvania that re-entry program and assists with the needs of the patient from injury until graduation and assists school districts in developing protocols, and it is a team-based approach. Therapists will make recommendations when the patient should return to school and activities with suggestions for modification, but it all needs to be signed off by your doctor. And so we need to really work closely with your doctors to let them know where we are in therapy and what stage of treatment we have gotten your student athlete to. All proposed medications, like modifications, I said, are communicated with physicians, and it may not just be your pediatrician or family doctor. If you're seeing a neuro-optometrist or if you're seeing a neurologist, all those doctors are included in that communication set. It's very important that we're all working together. So what can you do if you're concerned about your child or adolescent and they might have a concussion? First and foremost, you should call your family physician or your pediatrician and talk over what their protocols for handling concussion are. They may want you to come into the office and see them, or they may want to refer you to a specialist right away. You can contact us with questions. In Northern Virginia, in the D.C. metro area, you can contact the Children's Therapy Center. In the southeastern Pennsylvania and Delaware area, you can contact TheraPlay. And in western Pennsylvania, you can contact Positive Steps. Remember that early intervention and communication between caregivers and therapists, all your medical professionals, teachers, and coaches is really crucial for returning your student athlete not only to the classroom but back to the field. And our goal is that baseline function and maximizing their potential. So why choose TheraPlay? We provide individual treatment. We're a multidisciplinary approach. We have occupational therapists, physical therapists, and speech therapists in our offices. We work as a team so that if you're initially referred to an occupational therapist and we feel that a speech therapist would also really benefit your treatment, we would make those referrals and talk to your doctors about that. You will get a lot of home exercise program. Coming to therapy 2 times a week is not going to get you back on the field and in the classroom if you don't do home programs. And so we're going to ask you to do exercises at home as well. I'm sure as the vision therapy would also have those home exercises. We try to make therapy as fun as possible. We do as many fun things as we can. And TheraPlay family of companies has a lot of insurance options for you. All right, we're going to go at this point to questions. You can ask questions to myself or Dr. Edmonds at this point. We can start that chat. Dr. Edmonds, I actually have a question for you to start the question process off. At what point would you suggest that a family contact a vision therapist or a neuro-optometrist in their recovery process?
We generally don't have patients contact us directly. They usually they're referred by their physiatrist or their sports medicine doc or their neurologist, or sometimes it's the family doctor, but most of the time it's a concussion that's looking at the patient from an overall view. But a number of these doctors do screening and see visual deficits and send the patients to us. So most of our patients don't have, although it's certainly allowed to come to us directly, most of the time they come referred from an overall doctor that's managing the concussion on all aspects.
Okay. I'm going to ask one more question that I know a lot of families ask when we're talking to them about doctor referral. What's the difference between an ophthalmologist, an optometrist, a neuro-optometrist, and a behavior optometrist? Because a lot of times families don't know which of those doctors to go to.
Okay, so an ophthalmologist is an eye surgeon. So generally, there are surgeons, and Will's all of the surgeons kind of very specialized. So there's cataract surgeons, there's retinal surgeons, there's glaucoma surgeons. The one that we kind of work closely with in this is the neuro-ophthalmologist, but they usually only get involved when there's serious trauma where they need surgery on the optic nerve sheath, or where there's a complex, severe. They don't generally deal with concussions. because they don't, they don't do therapies. They basically do surgical procedures. So a general optometrist usually does eye examinations and medical eye care. A behavioral optometrist works mostly with children with developmental problems. So maybe a child with crossed eyes or a child that's not doing well in school that has kind of a natural. And a neuro-optometrist is sort of our category, is people who work with traumatic brain injury, stroke, concussion, or sometimes with neurological diseases like dementia or Parkinson's. But mostly it's stroke, car, sports accidents, car accidents, something with a concussion with good vision but loss of function in terms of the kind of things we talked about tonight. So it's kind of subtle differences, but those are the eye people are we're kind of specialized in our own areas, and that's how it works out.
Great. Thank you so much. So it doesn't look like we have any questions at this time. So possibly you're still typing them. But I want to thank you tonight for joining us on behalf of both Dr. Edmonds. Again, Dr. Edmonds is with Wills Eye Center in the Rothman Orthopedics Concussion Network. And my name is Sandra Wild Sutton, and I'm an occupational therapist with TheraPlay. So we'll give you another minute or two before we sign off to type in questions, because I know sometimes your questions take a little bit to type in. Here we go. We got a couple. Let's see. All right, so let's see. So Dr. Edmonds, do you want to take our first question here? I see, are there any vision exercises that we can teach students to use who are having early symptoms of vestibular systems as well as vision symptoms?
Yeah, there are some fairly easy. If you Google stereograms, stereograms are stereo images that in the stereo environment, the two eyes need to work together. If you're not in the stereo environment, and people who have double vision, one of the defense mechanisms, people can't tolerate and get around with seeing two of everything. So the brain in the short term will learn how to suppress one eye. So once you suppress one eye, you don't see double, but then you don't have any depth perception, so everything is flat. So stereograms that you can find, I mean, if you ever went down the shore, there's all kinds of pictures that you see in the window of eye games, which you have to cross your eyes or uncross your eyes to see the target, and suddenly the 3D image will pop out. So looking at stereograms, if the child can't see the stereograms, that's an indication that they're already suppressing one eye, and then that's an indication that they would need therapy to bring that back together. So that's an easy one. The other one is the convergence have what we used to call pencil push-ups, where you bring a pencil and try to bring it as close to your nose as you can without seeing double. That's another kind of a simple exercise. But often, again, if they suppress one eye, they won't see double. And if you watch, you'll see that one eye turns out and the person doesn't notice it's double. So they'll need more intensive therapy if you see the eye start to turn. So stereograms and sort of convergence pencil push-ups are kind of level one for mild things that don't really minimal symptoms, etc. So those are a couple of simple strategies.
Okay. I think from a vestibular standpoint, too, in therapy, those habitual exercises that I mentioned, so those things that you do as a habit, but do it repeatedly. So when I talk about standing up and sitting down, I'm saying standing up and sitting down 25 times, laying down and sitting up, but laying down and sitting up 25 times, laying on your back and rolling to your side, and then back to your back again, but 25 times. And certainly some kids won't be able to even manage 25 times. And so we work on what can they manage and what can't they manage. And a rule of thumb for us in the therapy world is if the concussion has happened in 3 months or less, and their headache, they come into the office and their headache, and we ask them, out of 10, tell me where your headache is right now, with 10 being the worst headache you've ever experienced, and 1 being a very minimal headache. And if they're a 4, we don't want to go farther than a headache of 6 in that first 3-month session. And so if you're starting to think about simple exercises you can do, you also want to think about how many repetitions can they do without increasing their headache. And sometimes in early concussion, the headache goes from 1 to 10 very quickly. And so we're also looking at, like, what's the recovery? Does it take you an hour to recover, or does it take you a minute to recover? And certainly that's something that should be managed by a doctor or a therapist. But you can start to do that in very small amounts at home. Our next question here, I'll let Dr. Edmonds talk about this, and then I can talk about it as well in therapy. Dr. Edmonds, what is the youngest age child that you have seen in therapy?
The youngest child I've seen with a concussion is, I think it was 7. He had a 7-year-old that had a fall and had a concussion. So that just happens to be the youngest one we've seen. One of my doctors on my staff is also a behavioral optometrist, and so she sees a lot of the younger kids that have developmental problems. So I usually come involved if there's been an injury. But for me, like, I haven't seen an injured child that got to me that was younger than 7. But I know she works with younger children with developmental eye problems.
Okay. At TheraPlay, I've seen kids with 2-year-olds and 4-year-olds who they believe have concussions. And so we'll work. It certainly is harder with a 2-year-old because they can't communicate what's going on. But parent might be recognizing symptomology, and we can help a parent negotiate what we believe is symptoms to a concussion, and what might be just, a stage that they might be going through developmentally or something else that might be going on. 4-year-olds we've seen frequently in the clinic. Certainly we're doing a very different kind of protocol for a 4-year-old because we're working in play, and we might be climbing over pillows and into an obstacle course instead of very standard exercises that you're going to do with an older student athlete. So a younger child's therapy following a concussion looks very differently, and we have to work closely with parents to make sure that the child doesn't re-injure themselves, because it's hard to keep a 2, 4, 5-year-old still. And so you have a whole new unique set of challenges with a younger child who has gotten a concussion. Okay. It looks like we don't have any more questions. So again, I want to thank you for joining us, and I want to remind you that the second part of our concussion series is November 6th at 7 p.m. So I hope to see you again at that time, or talk to you again. And Dr. Stephen Russo will be joining us from Springfield Psychological Institute. All right. Thank you again for
a quick plug for Dr. Russo. He's part of our Rothman team, and I've worked a lot with Dr. Russo as the psychologist. He has a wealth of experience. I learned a lot from him about comprehensive concussion management. He's really worth the effort. He's just a great guy with a lot of information.
Okay. Thank you so much. All right. Take care, everyone. Have a good night.